highlighted here. We'll start this with the SLET procedure, simple limbal epithelial transplant, the new horizon. The speaker is Dr. Mallikarjun. He's head of department, Shankara Eye Hospital, cornea and cataract refractive surgery.
Thank you, Dr. Sujit, and thanks to Dr. Srini for giving me this opportunity. Earlier, the SLET procedure was described by Dr. Sangwan in 2012, our own Indian surgeon. But earlier, it is understood that it will modify the stromal structure also. But basic now, what evidence says that it only regenerates the corneal epithelium. So it doesn't act on the stroma. So it is very important to know the limbal anatomy of the eye, because there is where the limbal stem cell will be there. And these limbal stems are unipotent. That means they produce only one type of cell, that is corneal epithelium. So these cells, they start migrating toward the center and form the epithelium, and it will be regenerating continuously. So that these limbal stems are taken and transplanted to the eye which has no limbal cells. That is the main principle of SLET. And advantages of SLET or other procedures are it is a single stage procedure and doesn't need any multiple procedures, and is easily affordable, and more importantly, it doesn't require any sophisticated lab, and anybody can do it. The indications, most common indication is unilateral limbal stem cell deficiency because of chemical injury and thermal injury, that is more common in India. And nowadays we are doing it for large, after large excision of OSSN and large pterygium surgery, recurrent pterygium surgery, and also in a severe VKC, which is also one of the cause for limbal cell deficiency. And the same conditions, if they are present in a bilateral, so we have to go for allogenic SLET. In autologous SLET, we use take the graft from the other eye. In allogenic SLET, we take a graft from a living relative or cadaveric eye. So preoperative consideration, we take a limbal tissue from the superior limbus, because there is where the more number of limbal stem cells will be present. And if you are taking for a cadaveric eye, it should be very fresh and less than 2 hours from the harvesting. And there should be a good intact limbal pellicytes. A pellicyte shows the presence of limbal cells. And in a recipient eye, it should not be a very dry eye, which is a contraindication for SLET, because the result will not be that good. And if there is very severe stromal ossification, that patient may later require the DALC or PKP for the visual correction. And preoperative ASOCT is a very good tool, because we won't see anything below the vascularized cornea. So if there is a thin cornea, and if there is a fully opacified cornea, if there is a perforation, all those things can be seen in ASOCT, and this will help us to do our surgery. Poor prognostic factor like eyelid, if there are antropion, ectropion, lag of ophthalmos, poor blink rate, and conjunctiva, they have symblepharon, severe keratinization, and these will be a poor prognostic factor. These things should be corrected during before the surgery, or if possible, it should be corrected during the surgery in the form of mucous membrane graft and other procedures. And if there is a very full thickness corneal ossification, the result will be poor. This is the procedure how we do. This is the chemical injury, and first you have to do a peritomy, first 360 degree, and actually you have to go into the plane of the vascularized area. So you have to dissect between the cornea and the vascularized panels, and you should not be very more enthusiastic to go deeper. And minimal cautery you have to do, and first what I do, I put the amniotic membrane with the glue, and you should be very careful that glue should not go to other areas of the ocular surface. Sometimes what happens, if it goes in the fornix, or if it touches the eyelids, there might be contact and adhesions later. And I do this sequential method of doing. First, I put one component of the fibrin glue, and later I put the another component of the glue. That would give us more control over the application of this glue. And this amniotic membrane should be tucked in below the conjunctival dissection. That is very important because it might, the conjunctiva might migrate there below the. This is how we harvest the limbal tissue from the other eye. This is a unilateral stem cell deficiency, so I am taking a tissue from the other eye. So you need to go little bit, dissect into the cornea and also the conjunctiva, limbal conjunctiva, and take a very small bit of conjunctiva. It can be just 3 by 4 millimeter, and cut them into a small, very small places. And these are placed on the amniotic member, which is on the cornea. And the tissues are not put on the pupillary area and also near the limbus. And later you put a bandage contact lens, and that is the completion of the surgery. Post-operatively, if you are doing autologous SLET, it needs a treatment combination of steroids and antibiotic, and it is tapered out usually for 6 months. 6 weeks, and BCL is removed once the epithelium is healed. On every visit, you have to do a fluorescence staining and see if there is a epithelial defect. You have to continue BCL till the epithelium heals. In allogenic graft, there is a very minimal risk of rejection. So that's why this immunosuppression and all should be continued little bit longer time, and also you should follow up the patient. So signs of rejection are, will be sudden drop in the vision or epithelial haze. These are the signs of rejection. When there is such signs are there, you have to increase the immunosuppression. The how SLET works actually. Amniotic membrane helps to in proliferation and migration of the epithelial cells that is placed on the cornea, and these tiny bits of epithelial cells, they start multiplying the cells. In each area, they start multiplying cells, and they form a small epithelial cells. And all this together, they coalesce and form a sheet of epithelium. That's how it works, SLET. The complications are very less in SLET procedures, and they do happen, and there might be a local LSCD at the donor site, is very rare, and the hemorrhages under amniotic membrane is common, but no need to do anything for that because it will absorb by itself. And there can be recurrent symplepharon, a sterile microbial keratitis, or persistent epithelial defect. And one more important complication that can happen, migration of conjunctival epithelium below the amniotic membrane, if the amniotic membrane is not stuck properly over the surface. This is the high definition ASOCT of SLET patient who has undergone SLET. This is on the first day. You can see the epithelial tissue here and BCL and amniotic membrane here. And on the 5th day, this epithelial tissue is just expanding. That means it is the cells are producing. And on the 8th day, you can see 2 epithelial transfer there. They are again growing over here and covering. On 10th day, again this area becomes larger, so it indicates that there is a epithelial growing here. At the end of 6 months, you can see these epithelial tissue, transplant tissue are not seen, and the cornea epithelium looks nice, and it is covered all of the cornea. There have been many modifications of this SLET procedure, and especially in the recurrent pterygium. Actually the pterygium is also one of the cause, it is due to limbal cell deficiency. After excising the pterygium, you place the amniotic membrane on the scleral side and on the cornea side. On the cornea side, you put a small bit of epithelial cells that would prevent the recurrence, and also it will replenish the stem cells. And this is the standard SLET procedure where we put the amniotic membrane and over that we put a epithelial cells. And there is a modification where you put a epithelial cell first, over that put a amniotic membrane. This has been published in and done in one Chinese group. What they say, this epithelial cells will not dislodge, and also it will help in the modification of the stromal opacification. I don't know exactly, I don't have, that is their claim actually. And one more complication of this SLET is the connectal epithelium can migrate below the amniotic membrane and come over the cornea. So to avoid this complication, the standard technique has been described, and what is done here is amniotic membrane is placed and epithelial cells are placed. Over that, one more layer of epithelial amniotic membrane is placed, so that these epithelial islands are sandwiched between, so that they will grow in that area only, and also it will avoid the migration of the congenital cells. In conclusion, SLET is a very good option for LSCD, and it is very easy to perform, and anybody can do this procedure. If you see a video and if you just see any article, one can do this procedure. Thank you.
Thank you, sir, for a very concise presentation on SLET. We'll take few questions for sir because he has to go for another presentation. Any question from the audience? So for the allogenic, do you give oral immunosuppressants also?
For allogenic?
Yeah.
No, I am not giving any oral. I start with topical only, and frequently I follow up the patients usually. And if there is a chances, if you see any signs of recurrence and all, then I'll go pulse therapy, immediate pulse steroids. And usually I don't give oral immunosuppression.
And any experience for you and using SLET in acute chemical injury or
Rejection?
acute chemical injury?
Acute chemical injury, I actually I have not tried, but earlier I used to do total limbal around 4 o'clock, 5 o'clock congenital transplantation. That has helped me, but I am not doing that in acute stage because it will be a lot of inflammation and all, the failure is more.
Dr. Vinay, any points to add?
Nothing much. The only other thing I want to ask you is, in allografts and alloslets, do you prepare the patient with the pre-op IVMP, IV steroids before doing, and in the initial post-op period, do you continue IV steroids?
Yes, I make sure that first inflammation is controlled, one thing, and also pre-operatively just I start 15 days, topical, that's all.
That's it.
Not oral.
In the perioperative period, no systemic steroids at all?
No, I'm not giving.
Okay, thank you.
Sir, in patients with OSSN and pterygium, when we do it, their main complaint is they're not able to see because of the amniotic membrane. So anything to be done for the central visual axis where we cover the amniotic membranes?
No, there are some surgeons, they are doing in the pupillary area, they are not putting the amniotic membrane and all. But what happens, this amniotic membrane over the period of time, it disintegrates.
So
Okay.
patient
So
counseling.
it is better to have amniotic membrane than not to have it. Because trying to cut in the center, then there is a possibility of this amniotic membrane may dislodge later. And it is very difficult, very thin and fragile structure. It is very practically it is very difficult to cut at the center at a hole, making a hole and all.
Yes. Thank you, sir. You have anything? Shabas, no. Okay.
If there are no other questions, thank you, sir.